What's happening in the sterile processing universe? It's Hank Balch here from Beyond Clean, and we're having a panel discussion today. And this whole event is worth 3 CE. So something tells me that you're going to want to tune in for it. Even if you didn't come for the topic, which I think it's a fantastic topic, you're going to stay for the CEs. Okay. We're going to be double threat today. It's a lot of CEs, but a lot of insight around a very important conversation, collaboratively educating for patient safety. The title of our panel today is Better Together. That's just kind of straightforward, but we're going to flesh it out. What does it mean to actually collaborate in sterile processing, but also outside of sterile processing with all the users and all the customers that we support in the clinical setting? Really excited about this conversation today. As always, we love to know who you are and where you're tuning in from. We're all about the social media networking here at Beyond Clean. So please take a moment right now. Don't do anything else. Go down into the comments section if you're on Facebook, LinkedIn, or YouTube, and tell us who you are, where you're from, and your opinions on collaborative education yourself. If you've had some experiences around that, if you love education, if you hate education, I'd kind of like to hear some insight, and then we'll keep the conversation going in the comments, but also in the panel today. At the end of this session, we'll put the link to go check out the CE quiz so that you can read the additional articles and then take that short quiz and get your certificate right away. It'll be downloadable and emailed to you. Without further ado, let's bring in some of our panelists today, and we'll let them introduce themselves. And then we're going to go into a little bit of what the practical side of education is. I think we talk a lot about education in the sterile processing space, but it's kind of amorphous. It's this thing out there that, somebody does, maybe the educator does, or maybe it's done to us at conferences, right? We get educated. But I think we've all got a part to play, and that's what I really want to dive into through this next hour of conversation. Let's start at the top and go clockwise. Bobby, could you introduce yourself to the sterile processing world here?
Yeah, absolutely. Good morning. And my name is Bobby Parker. I'm the clinical educator and clinical manager here at Beyond Clean. I've got about 10 years experience in sterile processing and happy to be participating in this panel.
Awesome. Thank you, Bobby. And Christine.
Hi. I have about 6 years experience in central sterile processing. I'm the manager right now of CSP. I started off as a surgical technologist. I did that for about 10 years. I was a late bloomer. Before that, I had a very colorful past with working in hospitals in different roles, from perfusion assistant to pharmacy. So, kind of had the whole gamut of what you can do.
That's awesome. I think that's going to come up a little bit, some of the themes in the background there. So that's great. Welcome aboard to the panel. Let's go next to Anna.
Hi, good morning, everyone. My name is Anna Gutierrez. I'm the sterile processing educator at Texas Children's Hospital here in Houston, Texas.
Okay, welcome to the show. And last but not least, Kelly, who are you and what do you have to do with education?
All right, thank you, Hank. Yes, I am Kelly Swales. I work as a director of clinical services for Censis Technologies. Most people know that as CensiTrack, our main product. And being director of clinical services, my team and myself really go to for my colleagues. And then along with that is going out to hospitals throughout the U.S., Canada, Puerto Rico, and doing clinical assessments to see how they're utilizing our products.
Awesome. So without further ado, let's go into the topic for today, Better Together, Collaborative Education. And kind of built into that question or that definition, as I alluded to in the intro, is to collaborate, you need someone else who's not you that's a part of that collaboration. So let's start right there. Who are the other people involved in the services or the partnerships that sterile processing departments provide to the healthcare space? Anybody can jump in here to kick us off.
Go ahead.
Go ahead.
I think one of the main departments that maybe gets unrecognized that we interact with is infection prevention. So for years working in sterile processing, we had no connection with them, never met with them, never talked with them. Now I've seen in the last 5 to 7 years where that's really evolved. You're seeing more interaction, more involvement, and I think that's a crucial role of sterile processing is to keep that interaction, because I mean they're so knowledgeable, we're knowledgeable, and we need to share all that with each other, as well as thinking of APIC guidelines. Well, how does that play into sterile processing?
So I'm kind of curious for the folks tuning in and for the folks on the panel here. Built in that question, Kelly, was who do you interact with or interface with on a daily basis? And you brought up, the point with IP is like in the past, we hardly ever saw those folks. And I'm kind of curious for everyone else, are you seeing IP? Like, are you seeing the same thing that Kelly is just laying out there, that IP is now more engaged or being more engaged either from our perspective or from their perspective? And are you getting to know those folks on more of that kind of regular basis?
Absolutely. So that was one of the departments that I was going to mention earlier is infection control, even other departments within the hospital. Every once in a while, as you're doing a project or maybe as you're trying to facilitate other areas, we have dental clinics in the hospital that I wasn't even aware that we had. And so, being able to communicate with them and work with them to have a streamlined process for sterilization and even decontamination that they might not be aware of because they're a simple clinic. We're there to assist and we want to assist. But with infection control specifically, there are so many guidelines that they have to recommend to us, follow up with. But at the same time, having an educator specifically to sterile processing, sometimes you might find that there have been maybe some guidelines or updates that they haven't gotten to. So collaborating with them, at least on a monthly basis, is super important too.
Has that been y'all's experience, Bobby and Christine? Is IP plugged in?
I think so.
Okay.
I've had a very good experience.
Yeah. Have you done anything in particular, Christine, to build that bridge or to pull them in, or at least when they've come in, to make that relationship more valuable?
I just think it's a relationship that's been fostered here at this hospital. I believe that there's a lot of collaboration and a lot of support. It's just something that simply just exists, and it's a wonderful thing, and it really goes across the board with all of the departments that we service here. I find that there is a lot of collaboration, a lot of respect, a lot of working together to get to the root of an issue and just make sure that things are always where they need to be.
Yeah.
Bobby,
Yeah.
I'm gonna throw the softball to you.
Okay.
Right now, we've laid out IP. All right, we got collaboration with IP. We got collaboration with some of these ancillary clinics, like the dental clinic example that Anna brought up. Who else out there on a regular basis is interfacing with sterile processing?
Yeah, if you've worked in an older sterile processing department down in the basement, you've got almost daily interaction with your engineering team or facilities, and so I think it's really important in terms of collaborative education to be on the same page with those guys when they're talking about steam shutdowns, when they're talking about getting inside a drywall. That was a very frequent conversation of going over SPD standards with my engineering team. So that was a big one for sure.
Great. Well, so y'all just saved the easy one for me. I'm going to say operating room is one that it's kind of baked in. And I know, that's like every day, the operating room relationship is in our face. So I know that's why y'all kind of went for these ancillary ones to kind of surround the OR. But you brought up a good one. Facilities management is one. There's materials management with supplies. We've got vendors, not necessarily departments, but they're definitely part of that interfacing relationship. We got EVS. Talk about headaches. We can do a fun conversation around that relationship. And not, that they just cause us headaches, but I think we probably cause each other headaches, to be honest, with uh, that topic. But to lay it out, I wanted to start with that question to provide a little backdrop with the complexity. So we're not just talking about one department, like how does sterile processing better work with the OR? That's a conversation I think that is continually being had in our space, and for good reason. There's a lot of brokenness between those two departments, communication, culture, trust, the whole shebang. But we've got a lot of folks that rely on us to do our jobs, or that we rely on to do their jobs. In the case of facilities, for example, to provide the excellent level of service that we need to. So the question from that then, in listing all these folks out, and we just still scratch the surface, there's many more where that comes from, but in all of those departments who need to know more about who we are, what we do, how we do it, and how we're supposed to do it according to the regulatory bodies, whose responsibility is it, in y'all's opinion, to take on that role to educate these outside groups?
I think it's mine. In some way, shape, or form, I think that it's if it's something that's impacting my business, I need to make it a point to see to it that those conversations are happening with my OR director, my OR manager, um, who happen to be on board. I'm very lucky. I have.
Rub it in. Everyone's sitting around here saying, Christine, that sounds like a great department. Everyone's on board, no cultural issues,
Well,
all the support.
not that there wasn't. Um, you kind of have to take it. My goal is to really make sure that I'm engaging and changing those opinions that have been kind of just a sacred cow, I think, for people to think. And as a surge tech, I was guilty of a lot of those opinions myself until I came down here. And you realize that there's a lot more to the story and a lot more behind the scenes. And you can go up and try to plead your case, and that's going to get you nowhere. But you can go up and slowly try to bridge these relationships and get small wins, and the small wins eventually add up to bigger wins, and it becomes an environment of trust and an environment of respect. And that's how we're able to really get our point across, that maybe we could improve a little bit on this particular thing, and working together, that collaboration with the OR manager, who has, both the director and the manager have such a good background on what needs to happen in Central Sterile. So it's just I really am lucky, I'll tell you what, to just have everything that I have. And that's not to paint a picture of perfection, but
Right.
I think it's imperfection in that door is always open. One of the biggest things that I was able to do to just take those small teaching opportunities, every day we huddle with the OR, and we make sure that to some degree we can just bring something up that's bringing something to their attention. And if we have to bring it up every day and kind of reword it, or whatever we need to do, then that's what we need to do to get them all on board.
Can I ask you a specific question? Because I
Sure.
love this practical application, right? This is this is the kind of thing that I want to get out of these panel discussions. Because if we said before, talking about it's one thing, doing something about it is a completely different scenario. So you've obviously done something about it, which is fantastic. That gives the rest of us hope that we can actually get to the place we want to get. But you mentioned huddling together. So who's huddling together? Is it just the department leader and the OR team? Is it the OR team and the sterile processing team? Kind of flesh that out for us.
Typically, it is myself and my supervisor. We go upstairs. The OR manager, the team lead for the OR, and the OR department, they're all in their lounge. I drag myself up there every day at 10. I start at 5:30, 6 o'clock. So about 10 to 7, we go up, we talk to the OR before their day really starts. Identify what we need to report, anything that we owe them for the day that we're aware of, any loaners, any concerns that we may have identified, any safety concerns that we've noticed. And then we open up the table to them and ask them what they have for us. And that was the scariest question, I think, the first week or so, that I would say, and what do you have for us, good, bad, or ugly?
And they roll out this scroll of things, and they're like, well, let me see.
And it was that way at first. And I would make a point to write it down. The biggest thing was for my own self, trying not to explain, but that's what, and because, but just letting them have that stage to say what they needed to say, to see me write it down, and then to come back the next day with follow-up to say that we talked about this, we addressed this is what we're going to do. And then maybe follow up maybe a week or so later to say, have you noticed, has there been any issues with this problem that you presented to us?
Beautiful. Yeah, I love that. And let me pull Bobby in here, because Bobby, I know you've had a similar experience with these OR huddle opportunities. What's unique about what Christine was describing is you could put the majority of that in just a communication category, but with some thoughtfulness on the side of sterile processing, you can blend that communication with education. And I'm curious from your experience, like how you've kind of navigated that same thing of, you're receiving information from them. You're kind of a visitor to their huddle, right? It's not your huddle, it's their huddle. How do you make the most of that opportunity as a sterile processing leader in those scenarios?
Yeah, I mean, you really want to be seen as the sterility expert for the facility, and so that consistency of just showing up and hearing them out is important. But it's also important in that discussion to be able to add context. So I think a really crucial thing that sterile processing departments need to be doing with their OR is going over like an expected turn time for trays. That if they expect it in an hour and a half, and that's just not a reasonable time to be able to clean and disinfect and sterilize the item according to standards, then they just need to have those expectations set on the front end and not in the middle of a crisis. And so, I think the biggest part is just consistency, earning that respect, doing something about the issues that they're bringing to you, and earning the right to make recommendations, earning the right to give some of that gentle education, so that it's a bit of a back and forth. And in my experience from doing that consistently, the feedback that I get is that they very much prefer whenever I'm there in the huddles. I didn't go every day. My experience was, once or twice a week, but they said that they really liked it when I was in that meeting, so that they could ask questions and learn the reason for why we do things the way that we do them.
I want to bring Kelly in here because you're kind of from an interesting perspective. I know you came from the clinical setting, you go the vendor side of things now. You still have a vested interest in the customers of sterile processing, understanding what's going on in sterile processing, but maybe for different reasons. And how do you navigate this or kind of approach this scenario of the vendor education that needs to happen, and that kind of on the ground dynamic of it happening at this department in this hospital? Like, what does that look like for you?
Yep. So one of the big things, I'm a firm believer in the why, and that we need to, when I work with vendors or I'm working with the OR, something with sense track with sterile processing, um, I'm a firm believer in the why, and we need to let them know kind of like why we're doing this. Why they're bringing on with our vendors, why we're bringing on LearnerLink, and how this is going to work and how this is going to benefit them. Not just saying, "Hey, I'm here to train you on LearnerLink today. Here's what we're going to do." No, it's making sure they understand that why, and then they have that buy-in. Along with that, it's that whole collaboration to say, well, here's what the OR scheduler person is going to do, and then here's what you're going to do, and then here's what sterile processing is going to do, and show how everybody kind of feeds into all this. So it's not all put on one person, and then to hear what they have to say. I want to hear their feedback. I want to hear something they don't understand. Help me understand, so that way we can educate and come out with success.
Yeah, it's a great point. And that why, flows through all these conversations. It's not just a vendor why, it's a why to the core of everything in sterile processing. It starts on day one of training and then continues for the rest of your career. If you're not asking why, you're asking the wrong question.
Right.
So, Anna, I want to ask you again, maybe from a little different perspective here, because we've had a couple of leaders, Christine and Bobby both, speaking primarily kind of from that manager perspective of it is my responsibility to do what I can as a manager to educate these other departments. But I'm curious, can you give some insight around who else in sterile processing has a responsibility to be educating, and what does that look like for them that's different maybe from the vendor side and then from the manager director side of things?
I think pulling in staff, direct staff that work within the departments is a great way to get buy-in. Having their peers teach one another really helps solidify, hey, I'm doing it, you should be doing this too, especially when it comes to something so important that's tied to, OSHA regulations or just something that's really important like that. And then having projects that include other departments as well. For example, if you see that there's a lack of scanning in one area and you want to get buy-in from that department, such as the operating room or even labor and delivery or other areas, then you can tie in those other educators in those departments, present the information, see if this is something that they would like to buy in, and making sure that when you communicate with them that you're doing it effectively. For example, if you have scanning issues, again, you can tie in your other educators and sending them an email of this is what we did to implement in the operating room. We would like to do this in your department. Is this something that you're interested in? This is the information from the Joint Commission saying that we must be doing this on an accreditation standpoint. And as soon as that department sees those words in an email, absolutely, I have to do this now. So really effectively communicating with them and letting them know this is why we have to do it, you're going to get that buy-in. No one is going to say no to a Joint Commission standard.
Right.
So just tying in other departments that way, I think it's imperative that either the manager or the educator for SPD is highly involved in training other departments, because SPD is it's not a very known entity, even in the hospital and especially in the community. And the only way that we're going to get there is if we start now with our educators with infection control. If you don't have a really good presence in your hospital, and SPD is still seen as a department that's almost optional, then you need to make that presence known. You have to be wanted. And the minute that you show how important we are, that's when they're going to say, hey, why aren't you in this meeting?
Right.
Important.
Yeah. That topic, is near and dear to my heart. That perception, you laid it out. There's a lot of departments in the hospital that don't even know we exist. They have no idea what we do, even if they've heard the name. And the critical role that we play in that surgical workflow, especially. And it's really shocking. Yeah, like even departments that are fairly close to us in terms of service level and complexity, uh, it really is still that unknown entity. Like we get sent, like floor mats to wash because we're the department that cleans things, right? Like, isn't that what y'all do? Y'all clean things? No. Well, yes, we do, but not necessarily. Floor mats is not the goal of sterile processing. I want to bring you back in on this topic, Bobby, because it goes back to a conversation that we recently had with you on the podcast about the role of OR liaisons in building culture and potentially in overcoming barriers. So like we were just talking about a barrier right now, which is the department's not known, but there's some other barriers that cause breakdowns in education, communication flow, that collaborative flow. And OR liaisons, in my opinion, and I think you probably share the opinion, they're a great tool in combating and overcoming these barriers. So can you talk about that that role, what it does, and again, like what are some of the barriers that it can uniquely engage with?
Yeah, I'm going to flip that and start with the barriers. The two that I think that have the biggest impact are time, like availability, and respect. We tell sterile processing departments that they need to go be cheerleaders for the department and educate the world, and we're all drowning in the realities of staffing shortages and just I don't know the challenges that this past year has brought, and that's a big issue. And so the question comes up: how invested are we in this collaborative education? Is it worth dedicating a team member that can really assist in that? And I think that it is. And the other big barrier I mentioned is respect, like earning the seat at the table to be able to educate and be heard whenever you do speak up. And I think the OR liaison helps with that. So this position is a go-between sterile processing and the OR, who is really the guy at the other end of the red phone. This is your customer service expert that the OR is going to reach out to with questions, with problems. They're going to be quality checking case carts and popping in on rooms to make sure things are going smoothly, and is really just the face of that sterile processing department, and begin to earn the trust of the OR that sterile processing is competent. They know the answers to my questions. They are consistently and routinely getting my case cart right. Whenever an issue does come up, it's documented, recorded, and addressed appropriately. And whenever you build that kind of confidence in the OR, you earn the respect to be able to educate according to standards, talk about how sterile processing is so important to patient safety, and you start to win some collaborators. I don't know, win some cheerleaders for your department. You start getting start getting surgical techs thinking about sterile processing when they're putting that case card up, and when they're talking about purchasing new instruments. And it really is a great bridge to start moving in the direction of having some collaboration with the OR.
And you said, Bobby, they're thinking about us, but they're finally thinking about us in a good way instead of a bad way
Yes.
during those scenarios.
Right. Yeah.
Yeah, that's great insight. Thank you for sharing that.
Yeah.
So time, respect, and I guess Anna's category would maybe be like awareness, recognition, kind of. Is there anything else, Christine or Kelly, that is kind of a known barrier that we need to bring up as one of the issues with us successfully educating our collaborative partners?
I think tenure. I think sometimes you may have staff throughout the hospital that they've been here for a certain amount of time, and sometimes you may be talking 20 to 30 years, and in that time, what they've learned about our department, or maybe somebody in my department may have learned about another department, they may have learned about that department 20 years ago, and that's all they've learned, and they never kept up with what has changed within that department. So the thought process is always about what was learned or known 20 years ago by somebody,
Right.
how a department actually works or operates. So
we get locked in time almost, right? It's like 1985, Groundhog Day forever.
And I always tell my staff, and we've leapt into the 1990s today.
Yeah, that's so critical. And that point is interesting because I thought you were going to go a different direction. I thought you were going to say, well, tenure is an issue because with so much turnover and the lack of continuity, then they don't know who's down there, who's doing what, what the plan is, if there is a plan, but you went the other way to say, hey, that kind of facility memory is hard to overcome if
Mhm.
it's a bad memory.
Yeah.
So yeah, it's really unique. Anything else? Like Kelly, do you have any other barrier to add at all for this?
I don't know. I mean, so one of the things I think the biggest barrier challenge that I see or have experienced is just not the different departments understanding how what they do affects the other department. So if you don't pre-clean your instruments, I get them down there and now they're crusted and they have to soak forever. Or if I don't assemble and sterilize this correctly, it's going to affect you in your OR times. And so I think that's one of the biggest things. And so I'm a firm believer, I've always tried to set up throughout the years, working in hospitals, is to where I feel everyone should have to shadow in the other areas. So sterile processing staff should have to shadow the OR to see what happens during that setup, to see what happens during that procedure, as well as then OR coming down and shadowing to see exactly decontam, here's what goes on, assembly, here's what goes on, sterilization.
Right.
And maybe bring in your clinics, have them come down and see what's going on.
I'm curious for the folks tuning in here, if you'll put in the comment section below, do you require shadowing, or does your hospital require shadowing for non-sterile processing professionals coming down into SPD during their orientation? So this would be things like nurses, like surgical technologists, even surgeons. We've had a couple of conversations on the podcast that as a part of that onboarding for new surgeons, they would even come down there, spend a couple of hours. Such a critical, important step. So if you do that in your facility, I kind of want to know about it. If there's any nuance that you think's really valuable, please put that in the comment section. But then also, there's been a lot of chatter from the other side of getting sterile processing technicians into the operating room, into the surgery, and potentially even in other areas. Like that's typically the place we want to put them is in surgery. Well, there's all these other departments we mentioned, like facilities, material management, L&D. How often are we getting our technicians on the other side of the coin during a steam outage, to figure out, oh, that's what they're going through. Like, that's why it takes them 6 hours to get this thing back up. It's not just a switch to flip. I'm curious, has anyone sit your employees anywhere besides the OR in training or onboarding?
We've tried to do that, and we were all set to go, and unfortunately, COVID hit.
Mm-hmm.
And it just changed the face of how we tend to do everything now. It has impacted not only ORs across the country and central steriles across the country and patient populations and OR schedules. It's made it almost impossible for some time for us to be able to get staff to be able to go upstairs. When the OR is slow, we're slow. So we, on slow days, we can't even get people up to see cases that are going on because till the people who come in need to see those cases, the day is done.
Right.
It's almost a little bit of one of those things that we talk about, and we really, really mean it when we say we want you to get up there and everybody is on board. It's just until it actually happens, it seems like it's such a, I don't know, is it really going to happen? Is it just something that we talk about and happily go about our business? But I'm sure that someday soon it'll happen. Once we get through what we're going through with the Rona, I think
Right.
that we'll get on the right path.
So outside of that, because obviously that has had a tremendous impact on all kinds of things, you're right, from the training to supplies to even like workflows within sterile processing. This has been quite a couple of years for us. But that piece about that shadowing or that viewing of OR cases, I know you didn't say this, but I'm going to use this phrase, like falling through the cracks, kind of, as a part of that collaborative understanding is not uncommon. Like I hear that from a lot of folks, and I even, my own scenario as a director and manager, it's very, very hard, even if you're talking about one technician, to pull one technician from the floor, because what happens is if you send one person, then all of their peers are like, hey, when's my turn? Well, if their turn is not for another 3 months or 6 months, like you're almost doing more harm than good to your department culture, because now you're like, you got some special favors, things going on with people who get to spend the day in the OR. Everyone else is down there holding the bag. But and this may be a question again for the comment section, but is it in normal circumstances outside of the virus, is it reasonable to bake that into a mandatory check on your onboarding so you do not complete your 90 days or your 30 days until that happens, to kind of force to force the OR's hand to say, hey, this is the last thing this person needs to do before they're checked off? Is that a reasonable step? Has anyone done that before on this panel?
I'd like to take the lead on that one.
Sure.
So, with Joint Commission standards, it's actually one of the recommendations that they provide is that we do proper education to the staff. I believe in sending the operating room staff downstairs to SPD, but also SPD to the OR, maybe even other departments like central supply, so they know the logistics of implant ordering, those kind of things. It's really important for all of us to know what one another are doing so that we can hold each other accountable to those things. One of the things that I write down stuff as I think about them. One of the things that is really important is inspecting what you expect from your staff. And so if you're not following through on, an idea, you did the education, you did the training, and everyone got checked off, they knew what they were doing, but then you don't circle back around and follow through or follow up and actively round and show them, hey, can you show me how to do this? If you're not presently there inspecting it and letting them know, hey, I'm watching you, not in a bad way, but just making sure that they're knowledgeable of it and that I'm going to peek in on you every once in a while. That maintenance is going to keep up with the trends of all the education and hard work and even projects that you got completed on one day. So if you're not doing that, then there's no reason for you to do a project. And that's super important. Another thing, like a barrier. There's two things. One of them is communication and the other is professionalism. If your staff don't actually know how to properly communicate and how to write a professional email, that message might not come across adequately. And so it's super important that part of the education is building up your team to be professionals. You have so many other departments that have to go to college and doctors. You have so many people that have these higher education degrees, and yet you have sterile processing department technicians that some of them come off of the floor, some of them come from the street, and they're awesome, amazing staff, but they just don't have the proper tools to communicate effectively to other departments. And so if you're not building up your team,
it's the soft skills.
Right. Then that message is not going to come across, and you go up to the OR and they may assume that they're not professionals. Just because of the way that they reacted. And all of this stuff, the soft skills, those are built on, those are learned, those are addressed. And then you keep up with them by, again, circling back around and inspecting what you expect so that it properly happens.
So that brought up another barrier, and then I think we're going to move on to another topic here, but it kind of has been undergirding some of the conversation, but you alluded to it just now with the different degree pathways and, the impact on professionalism potentially. But there is an assumption. I'm not even going to ask the question. I'm just going to state it as an answer. There is a presumption oftentimes on the part of OR staff, nurses and surgeons especially, that they automatically know more about sterile processing than the inverse, that sterile processing knows about surgery, right? Like it's kind of uncommon for a sterile processing tech to stroll in the OR and be like, yeah, guys, how hard could this be? I know what you're doing. Like we kind of get the fact that it's complex and that there's a lot of things that could go wrong, but it's not uncommon. And I know I'm painting with a broad brush, but here I go. It's not uncommon to have a nurse or a surgeon either stroll down into sterile processing or just kind of say this, that, how hard can it be? Like, why do y'all keep screwing this up? And that presumption and that disconnect, I think, is really a barrier and a challenge, for this collaborative type of education again, because if you feel like you know it, then you're not going to be receptive to learning and to growing in that knowledge. It's a much better starting place to know what you don't know and be a little humble about it, and then learn along the way. And yeah, like that, I just think that's something that we're going to have to overcome. And if you disagree with me, you can send me hate mail at hank@beyondclean.net. Okay, so moving on here, we've brought a couple of these already up, so we don't have to repeat them all, but what are some things, as I said before at the beginning of the panel, I really want to focus on some concrete takeaways that folks can walk out of this and say, okay, I want to go do that thing. Like I want to do this small step that can help me get to that collaborative approach that you've been talking about on the panel. So what are some examples of some things that you've done or perhaps you've seen out there in the space of collaborative education with your sterile processing partners around the hospital actually work well?
So one thing that I did years ago when I was working in the hospital, first SPD week, is I had open houses on different days and times of the week where I invited everyone, so all of our customers and anybody else that was curious to see what goes on. And when you came into the department, I had different, instrument sets open that they could look at, they could kind of play with. But then along with that, they could put on a bunny suit and hat and everything, and then come tour the whole department. So showed them basically the whole life cycle of a container, from decontam all the way to storage. And it was really eye-opening for a lot of the people that came through. Like they had no idea. And so I found that to be very beneficial and a nice way for them to kind of, no pressure, just kind of come on through, take a tour and see what's going on. And I think it really helped with that interdepartment relationships.
Yeah, I love that.
We had done that here and it was very well received. And I will say I was surprised. It wasn't the people that I expected to come that came to the open house. It was people who were really just curious what we did inside our department. In other words, the OR, we did have some people come down from the OR just because they wanted to support us. But most of the people were people who really had no interaction with CSP at all. And they just really were curious what it was we did. So it was a good way for us to spread the word.
That's such a rare opportunity too, to be able to go inside a department that you don't work in, and just see what's going on, ask questions. So on the practical side of this, how did y'all advertise? Like, was it an email? Did you put a poster outside your department? What did you do to kind of bring the folks in?
So we had a monthly newsletter that went out in our facility. And so it was in there. Along with that had made signs and hung them on our doors. So as they're dropping off dirty instruments, picking up clean, they would see it. And then along with that, just kind of putting out emails to the departments that we serve, asking them to share with their staff and hanging signs in their break rooms so they all knew to come down.
Awesome. Was that about what you did too, Christine?
We did it. We have daily huddles, our daily safety huddle at the time. That's what we were doing, where all the leaders get together. Now it's done on Zoom, but at the time that we did it, we were still meeting in person. So every day before CSP week and during CSP week, I was telling them we also had free hot dogs. So I actually had people from the lab bring in hot dogs. Maybe I shouldn't have trusted that. I don't know, but anyway, they brought in hot dogs. That was our big selling point, and hot dogs in a gift basket. So we did that, and then also we had the nursing leaders share it at their daily huddles for all the shifts. So we really tried to get the word out, and I feel as though we had a really good response. I was a little surprised.
What about you, Bobby? Any good examples of collaborative education going right?
Yeah, I listened to a really great interview today from an innovative sterile processing company about a micro-credential that was taken place by a surveyor and recommended to infection preventionist. Yeah.
Familiar.
Yeah. So I don't know. There's a lot of great conferences, podcasts out there about sterile processing. And so when I was managing, I went with my infection preventionist to an APIC conference that was local in town, and listened to a presentation on duodenoscope culturing, and we just talked together about that. She didn't have much of a background in sterile processing, but just wanted my opinion on helping develop that policy. And so you could really leverage a lot of resources. Like, we don't have to be the educators. We just have to be a smiling face that can invite somebody to go with us to some education. And so I think that's tremendous. In terms of advertising our local department, we had this really great sterile processing newsletter that we put out. And what we focused on in that newsletter and putting it out was some sterile processing education. We talked about our staff members who had been certified, some basic stats about how much we had processed, but we also carved out sections of that newsletter to talk about sterile returns and why it's important to track those, and to keep track of preference cards and making sure that we have effective use of our labor in that way. We talked about inspection points and how long it takes to inspect a tray, and what are some of the different things we do to inspect instruments. And as we put those little nuggets of information kind of mixed in with just a general department newsletter, I was really surprised to see the number of people who would comment on those and interact with it. We emailed that newsletter out each month to all of our list of surgeons. We had to wrangle administration to get permission to have that list of surgeon emails, but once we got it, we were emailing that out to surgeons, to our managers in the facility, posted them in break rooms everywhere, in the OR everywhere. And there were quite a few people who said that they read it every month and thought that it was really interesting. And so that was just a great way for people to know what's going on in sterile processing, and again, hear why we're important to patient safety.
Awesome. I don't want to spend too much time on the micro-credential piece, but I do want to echo what Bobby said about that I think a big opportunity that we have yet to tap into is that shared credential space. We've seen a lot of movement in recent years toward collaborative educational events that are pulling in IP and sterile processing, pulling in OR and sterile processing. So we're starting to see more and more education together. But up until very recently, we've all had our own credentials. You got sterile processing credentials, very narrow. You got surgical tech, very narrow. You got operating room, very narrow. And neither the twain shall meet, But what's really unique, one of the really unique things about that new Beyond Clean micro-credential is it's specifically made to bridge the gap and to educate all of those users around a central theme of sterile processing, but from a multidisciplinary or interdisciplinary perspective. So yeah, that's a great example. I interrupted someone. Who else was adding
Just me.
Okay, go ahead.
I'm always talking.
Okay. That's why you're on the panel.
I was just going to add that one of the things that I found also to be really beneficial when you talk about collaboration with physicians, um, and this was probably one of the scariest things I've ever done, was I decided to put together a survey and give it out not only to the OR staff but to the physicians, identifying what they're looking for, what are their biggest concerns, what are their needs, what they, just all the whole gamut. And it kind of made me sick in the stomach to hand out this survey. Once I got it back, though, it really does give you a baseline of where you need to improve, and really improve, not where you're guessing where you think you need to make your improvements, but you're really responding to your customers because they're telling you exactly what you need to know. And P.S., if you don't want to know, don't ask. I wanted to know, so I asked. And
That's great.
the information itself that I got back was very useful to know, where everybody was as far as, um, especially the education piece of things, and just really how we can service our customers better.
Yeah, that's a great point about the survey, and honestly, like that may be a great kind of segue maybe into this last section, because we've been talking about tools and resources. Like the survey is a fantastic resource. The newsletter that Kelly and Bobby both brought up, like that's another great tool to educate in this way. That's maybe a little less scary than a survey, to your point, but I understand what you're saying. But that brings us data, which Kelly, I know your team is huge on data and the importance of data and how data tells a story. And even in this kind of general conversation around collaborative education, there's still a story to be told about how well are we doing these things, how often are we doing these things, and that data portion, even if you're keeping track of how many in-services you're doing per year and who is attending those in-services from these other departments or what other departments you're going to do in-services, I would assume like that's valuable data points to be gathering. Am I correct?
Yes. Yep. And that's, when you look at all this too, we need, as you said, we need that data. We need to show we've done this. So I even tying in competencies to this.
Mm-hmm. And even like, honestly, to the fact that Bobby brought up with the newsletter, using your department data to educate your partners around the facility, like how many instruments are we processing per year? Like I've seen that stat a lot, which is kind of shocking for even some of these small departments. It's like millions, millions of unique devices. Whoa, I have no idea. That's crazy. Or, even something as simple as it takes that long to turn something over and compliantly do it, and you can show it from your tracking system data. That is that's a great foundation, I guess, is what I'm trying to say, for a conversation around education that's not just someone's opinion, but it actually is the reality of the department. And it positions us in a way that I think everyone's brought up so far as the expert. Because if we know what's going on in our department and can show it with the data, and when we're educating, not only are we regulatory experts, but we're this specific department. This is what's going on. These are where the challenges are, the gaps are, the opportunities are. And all of that ultimately, I think, comes back to data. As we wrap up here, I'm just going to kind of go around the circle again. And if you have any other tools or resources that you think would be valuable for this discussion around collaborative education, or just ideas, like is there anything else that we haven't mentioned that you want to throw out there as kind of a takeaway? And we'll start with Bobby.
Yeah. This is one I've heard you talk about before, Hank, but I think, 95% of being part of this collaborative education is just showing up And sterile processing tends to get left off the invite list to a lot of these collaborative projects. You have new instrument sets that get purchased, and everyone's surprised to find out we don't have the equipment in SPD to sterilize it because nobody asked me, And so something real practical to do is just find out what meetings are taking place, and particularly related to surgeries and infections, and figure out a way to get a seat at that table. Try to get invited. So if you're not going to your facility's monthly infection prevention meeting or infection control meeting, reach out to your infection preventionist and request an invite. If you are allowed to go to a surgeon-led OR executive committee, try to get an invite to go in and just at least observe and listen and hear about the plans for the policy changes coming in the OR, or surgeons that are being recruited that are going to be showing up in 4 months that may require you to purchase more instrumentation. Just getting a seat at the table is a big step in the right direction.
Awesome. Okay. Christine.
The most recent thing that I've been really trying to make a point to do is putting as much education as I can on our intranet-based learning system, so that we can really keep a better finger on the pulse of competencies in education. It's all documented, it's all there, and staff can do it on their own time. They, when they have a little downtime. Also extending it not only to maybe the OR staff or other departments, but also perhaps to other CSP departments within our particular system.
I love that. Like leveraging that technology and that module type scenario that everyone is familiar with, but using it to educate your customers and your partners. Yeah, that's brilliant. Great. Anna.
In here at Texas Children, something that I've helped to create is a survey. So it's infection control does walkthroughs in our departments every once in a while. And I felt that it would be beneficial to myself, but also my team and my managers to kind of have a follow through. Infection control does the walkthrough. They tell us what they saw, but they don't deliver any feedback. They don't deliver any options to fix anything. And so sometimes our managers, sometimes our staff really don't know where to start, or they might not even have time. And so something that I did was I created this survey, pretty extensive, but I do a complete walkthrough. I transfer that information onto an Excel sheet, and I come up with options to resolve those issues. And we don't tackle them all at the same time. Every month, 1 tower, 1 problem. And I set up a meeting with the managers or whoever's in charge of that area. I get staff involved so that they can have buy-in, and we help find solutions to those issues, one at a time. You don't want to overwhelm your staff either, but at least having those small wins, and you're seeing that there's a resolution at the end every month, and then coming back and having a meeting to where you can say, hey, we resolved this. Let's move on to the next thing. It makes them feel like, hey, I got this accomplished, and there's a light at the end of the tunnel.
Right. I'm sensing a theme with you. You like the idea of auditing, which I think is something that we need a lot in our department. So great sharing, great idea there. Kelly, we'll give you the last word here. What is a tool or resource or idea that you think is a big takeaway from this conversation?
So, I'm going to go right to the top here. I think our executive leadership in facilities needs to be more aware of sterile processing. So you never hear about sterile processing. It's kind of that forgotten department until something goes wrong. And so think of like when the ERCP scopes, then everybody knew what sterile processing was, and everybody knew about scope processing. So with that, I think we need to go right to the top and get the C-suite leadership involved. I like to see that when we talk about all this collaboration between the departments, well, sometimes you need to go right to the top and say, we need your help. We need people to help understand. You know, we're not a revenue generating department, for at least the majority aren't. And so I think it gets kind of forgotten. And so, yes, neither is environmental services or facilities. But if something's dirty or we don't have heat, everybody's going to know about it. Whereas we don't see that, you know, with sterile processing, they don't know anything until something bad happens. And so I almost feel like go right to the top, get them involved, as you said, be in those leadership meetings so that you don't end up with, hey, we're bringing in new surgeons and here's this new, you know, these new instruments. And then here we don't have the equipment to process them. So we need to get their buy-in. We need to get them involved and go right to the top and bring them in.
Right. Yeah.
Even thinking of big, you know, and kind of a big picture, I live in Minnesota. So we have the Minnesota Healthcare Association, that it's all executive leadership from all the hospitals in the state that belong to this. I would love the opportunity to go there or have somebody go there to one of their monthly meetings and do a presentation on sterile processing so they understand exactly what it is and how it impacts the whole entire facility.
I know Bobby brought up adding all the surgeons to your list of monthly newsletter, but the C-suite, another great addition to start tackling that same challenge as you said, get that perception and that awareness all the way from the very top, all the way down to the technician level. So that's great. I want to thank everyone for a fantastic panel discussion today. The time flew by, as it always does on the show, but thank you all for coming and sharing your insight. I want to thank everyone for tuning in and the great conversation that's happening in the comments section. I'll put the link to the CE quiz below that has the additional bonus articles. And if you've got any other questions regarding this panel discussion that you don't want to ask in the comment section, but you want to ask one of the panelists, I've got their contact info, so you can reach out to me at hank@beyondclean.net, and I'll get that over to you and get you all connected. And until next time, keep fighting dirty, but also keep doing it together because we are better together. And we will talk to you again soon. Have a great day.